All right. So what two lab values did we talk about that indicate hepatocellular injury? Does somebody want to shout it out? Okay. AST and ALT, and those would be elevated. So an elevated alanine aminotransferase, which is your ALT, and an elevated aminotransferase, which is your AST. So those indicate that there has been damage to the hepatocytes. And so those are when they're elevated, they're indicating that there's hepatocellular injury. Which labs indicate liver synthetic dysfunction? So, putting together compounds, or what the liver makes, what the liver produces.
Oh, yep.
You got a private messenger.
No, you borrow.
Oh, didn't answer.
So if we have liver dysfunction, synthetic liver dysfunction, we have decreased synthetic function of the liver. All right. So that's decreased making of substances. So we have to think about what the liver packages and puts together. So we'll see decreased albumin, decreased platelets. We'll see decreased clotting factors, but remember that a decreased clotting factors are going to lead to an increased PT-INR. What questions do you have about the synthetic dysfunction of the liver and the lab values associated with them? Right. So with our patients who have cirrhosis and they have decreased albumin, what drug dosing considerations do we have to consider for a patient who has hypoalbuminemia, so low albumin in the blood? I hear crickets on the messages. Does somebody in the classroom have it written down? Okay. So if we have hypoalbuminemia, because as we talked about here, we have decreased albumin, we're making less albumin, so we're going to have less albumin in the blood. We have hypo, which is low, albumin, which is the protein, emia in the blood, so low protein in the blood, so low albumin in the blood. We know that a lot of our drugs are protein bound, so we're going to have reduced drug protein binding, because we don't have any protein for the drug to bind to. So we're going to have that binding is going to reduce, and that's going to make the drug more available. So we're going to have increased drug levels. Does everybody track that? So quiet. Either that or you're sitting way far back in that auditorium and I can't hear you because you're using your 12-inch voices instead of your outside voices. Right. Which labs indicate excretory function? So what is being excreted from the liver? Right. So the liver is responsible for excreting substances. So if we have excretory dysfunction, that's we're not excreting substances like we should. So we have decreased excretion of substances. Substances that are excreted from the liver include bilirubin. So if we're not excreting it, bilirubin is going to go up. So it's going to be increased. Another substance that is excreted by the liver is ALK-Phos or alkaline phosphate. So if we're not able to excrete that, we're going to have an increased ALK-Phos. So it's not just enough to know which lab values go with which function of the liver, but you have to know whether they increase or decrease in dysfunction of the liver or in cirrhosis. Okay, which labs indicate liver detoxification dysfunction? All right. So our liver is responsible for detoxifying substances, and if it's not working, one of the substances that becomes a big issue for patients with cirrhosis is ammonia. So that ammonia cannot be converted to urea, which is a water soluble and able to leave the body more readily. And so if we are not able to convert that to urea and get rid of it, we start seeing an increase in ammonia. Right, so just to if our ammonia increases, what happens to the patient? Can you yell a little bit louder, like you're jumping out of airplane?
Hepatic encephalitis.
All right, hepatic encephalitis. All right, so just to review, AST, if a patient has cirrhosis or liver impairment, AST is going to go up or down or stay the same. Right? ALT is going to go up or down or stay the same. Right? Prothrombin time is going to go up or down or stay the same. INR is going to go up, down, stay the same. Albumin is going to go up, down, stay the same. ALK-Phos is going to go up, down, stay the same. We're losing people on that one. Total bilirubin is going to go up, down, stay the same. And ammonia is going to go up, down, stay the same. All right. So what are the most common causes of liver damage or cirrhosis? I'm sorry, I couldn't hear that.
Steatosis, I don't know
Steatosis. That could potentially be because that could be related to one of the conditions. I heard viral. Alcohol, great. All right, so alcohol use disorder is the number one cause of liver damage and cirrhosis. Untreated chronic viral hepatitis is another common cause of liver damage and cirrhosis. And then the metabolic liver disease, we're seeing more and more of that. It used to be called non-alcoholic liver disease, fatty liver disease. Now we're calling it metabolic liver disease. All right. And this would be where that steatosis comes in, where that fat buildup on the liver cells and on the liver. So alcohol use disorder, chronic viral hepatitis, and metabolic liver disease. I saw some people say portal hypertension. Portal hypertension does not cause cirrhosis or liver damage. Liver damage and cirrhosis causes portal hypertension. All right. It is the stiffening of the liver. It is the scarring of the liver that causes that backup and the blood not to be able to flow through the liver so well. And that causes portal hypertension. So it's the stiffening, the dying off of the liver, the inability of the blood to be pumped through the liver that causes portal hypertension, not portal hypertension causing liver failure or liver damage. So if a patient we suspect has liver damage or cirrhosis, what are two signs that are specific to cirrhosis? What physical things would we be looking for on a patient? So that's what, when we're talking about clinical presentation, we mean, what does that patient look like? What does a patient with cirrhosis look like? Well, they could look normal. They could look like you and me. But if the liver disease is further advanced, how might they look? Right, so we might see an enlarged, swollen abdomen that could indicate ascites. So they have an enlarged, swollen abdomen and they are not pregnant, but they look like they could be pregnant because they have so much fluid buildup in their stomach. That would be specific to cirrhosis. The other one is that when bilirubin accumulates in the body, the patient will turn yellow. So they will have yellowing of the sclera, which is the white of their eyes, or they might have yellowing of their skin underneath their fingernails, and that is jaundice. All right, so jaundice comes from the buildup of bilirubin in the body, causing our skin and our white areas to become yellow. And then because of that portal hypertension, we start getting fluid leaking into the abdominal cavity and we get ascites. Some of the other clinical presentations that we talked about, fatigue, malaise, those are not specific to cirrhosis. You can be fatigued for a lot of reasons. You can have malaise for a lot of reasons. Those are not specific to cirrhosis. Which complications are a result of portal hypertension?
Accumulation of fluids.
Okay,
The
so
ascites, it's
Okay.
gonna.
Yeah. So ascites is one of them. So the portal hypertension is going to cause the backup of fluid into the abdominal cavity for multiple reasons that we talked about. And so we can see ascites as one of them. because we get that vasodilation in the GI cavity that increases the fluid in the cavity. We also get the neurohormonal, the activation of RAS, renal aldosterone, angiotensin system. Get the activation of that, which leads to salt and water retention. And so we get ascites from the portal hypertension. And then the other,
sorry.
go ahead, Victoria.
No, I was about to say esophageal varices. I don't know if you spell it like that, but
Yeah, thanks, Victoria. So yeah, esophageal varices. So because we're having more fluid go through those blood vessels in the abdominal area, we're putting pressure on those blood vessels. They're getting thinner and weaker, and risk of what's the risk of esophageal varices for a patient?
Bleeding.
Yeah, they could rupture and we could end up with a GI bleed. So if a patient has ascites, what are your recommendations for this patient, both non-pharmacological and pharmacological?
pharmacological, I think that you give spironolactone 100 and furosemide 40, I think.
Okay, so ascites management, who agrees with Victoria that we would give spironolactone 100 milligrams and furosemide 40 milligrams?
I agree.
Yes.
All right, we have somebody in the audience there and somebody online here. So yes, so we are going to use combination diuretic therapy. We use the spironolactone 100 milligrams. Spironolactone is an aldosterone antagonist. It's going to shut down that RAS activation. And the furosemide 40 is going to help maintain the potassium balance to make sure that we don't get too much potassium, because spironolactone is going to increase the potassium. All right. For some of the non-pharm, what are some non-pharm things that we think of? So I'm seeing in the chat that we're going to have sodium restriction. It's not very beneficial to have fluid restriction in these patients. It's more important to have sodium restriction. We're going to want to avoid, which over-the-counter medicines do these patients need to avoid? NSAIDs. So give me some examples of NSAIDs. All right, excellent. So avoid NSAIDs like ibuprofen, naproxen, aspirin. Why are we avoiding these in patients with ascites?
Increase the retention of fluids.
Yeah, so NSAIDs increase the risk of sodium and water retention. So that's going to be problematic, cause the ascites to get worse. We're not avoiding them in ascites because of the risk of bleeding. That would be a reason we would avoid them in esophageal varices, but in ascites, it's because NSAIDs increase sodium and water absorption, or not absorption, but retention. Right? Want to avoid alcohol, and then we want to make sure that we're giving that spironolactone and furosemide in that 100 to 40 ratio. So you'll see maybe on the exam different ratios of the medicine, and you have to pick the one that goes along with the correct ratio. So 100 to 40, 200 to 80, 300 to 120, 400 to 160. When do we give albumin for ascites?
5 liters.
So I heard in the back there that we only give albumin if we've removed greater than 5 liters during paracentesis. Right? And what questions do you have on managing ascites? Right, so your patient was started on spironolactone and furosemide. What are you going to monitor the patient for?
Hyperkalemia.
Right. Right, so we're going to monitor the patient's swelling. We're going to monitor their abdomen. Make sure that the swelling is not getting bigger, is going down. Going to monitor their abdomen for abdominal tenderness to make sure that it's not getting worse. The ascites is not getting worse. Weight loss can be an effective measurement for us to determine to make sure that they are having fluid loss or not having fluid gain. We're going to want to make sure that we monitor the potassium and the sodium. So the potassium, because the spironolactone is potassium sparing, is going to cause the potassium to go up. The potassium, because the furosemide is potassium wasting, and is going to cause the potassium to go down. Hopefully that 100 to 40 ratio keeps the potassium at a normal level, but we still want to make sure that that's happening okay. Also monitor sodium, make sure their sodium's not getting too low. Because both of these work in the kidney, we're going to want to monitor the serum creatinine to make sure that we're not sending them into kidney failure. And then gynecomastia, so asking about breast tenderness, especially for men, asking them about breast tissue growth. And then monitoring for dehydration. So I think we hit those that were answering in the chat, hit almost all of those, if not all of those. What questions do you have about monitoring spironolactone and furosemide for efficacy and safety? These right here are efficacy, and these right here are safety. All right. So if a patient has ascites, what do we have to consider as far as drug dosing for those patients who have ascites? Think about what ascites is. Ascites is the accumulation of fluid in the abdomen area of sodium and water in the abdomen area. Think about the impact of all that extra fluid on drug dosing. So with ascites, again, we have that increased fluid accumulation in the abdominal area, and that's due to the salt and water retention. So these patients with ascites have a lot more water in their system, right? And so we have a lot more water outside of the vasculature. So we're going to see an increased volume of distribution for hydrophilic drugs. So hydrophilic drugs are going to, when we have them in our system, are going to look for water because philic means they love water. So they're going to go look for the water. And if there's more water outside the vasculature, they're going to try to get there. And so the volume of distribution, where that drug is going to go, it's not going to stay in the vasculature. It's going to try to find that water, going to the area where there's ascites. And so you'll have less drug in your bloodstream, and so the drug will not work as well because you don't have enough drug in your bloodstream because it's going out to the other areas where there's water, like into the abdomen. All right, so
Can you
somebody,
repeat that again? I'm sorry.
okay, yeah. So when we have ascites, we have increased fluid in our abdomen, right? We have all this fluid accumulating in our abdomen area. And this fluid is water because it's salt and water. So in your abdomen, you have extra water. So if a drug is hydrophilic, it is not going to stay in the vasculature, in the bloodstream, because it's going to search out where there's the most water. So it is going to leave the vasculature and go distribute into areas where there's lots of water, like the abdomen. So then our drug concentration decreases in our vasculature because the drug is leaving the vasculature, going to where the water is. If it's a hydrophilic drug, so if it's a water-loving hydrophilic drug, it's going to distribute throughout the body instead of staying in the vasculature. So that causes our drug concentration to go down. So if it's a hydrophilic drug, we might need a higher dose of that drug to get a therapeutic effect, because it's distributing outside the vasculature. All right, so patient has ascites. What's the risk for SBP? So spontaneous bacterial peritonitis. What risk factors for patients with ascites increase their risk of having an infection?
History of a fruit.
If they have like low protein concentration.
Okay, thank you.
And also I think if they used to have SBP.
Okay. So, right, if they have had prior SBP, they're going to be at increased risk of having SBP again. So we usually put them on prophylaxis. If they have an active variceal bleeding, so their esophageal varices are bleeding, that is, their bloodstream is open up to all the bacteria in the GI tract, increasing the risk of SBP. And then if they have low acidic protein levels. So which bacteria are typically responsible for causing SBP?
Gram negatives.
I hear some gram negatives. All right, so E. coli and Klebsiella, think about bugs that live in the gut. E. coli lives in the gut, Klebsiella lives in the gut. So our gram-negative bugs are the most common bugs that we attribute to SBP, and them getting into areas that they should not be. We can also have Streptococcus and Staphylococcus, but those are less common. That being said, what's the first-line treatment for SBP? Oh, we have somebody in the chat using the brand name. Ooh. That person must work in a hospital. All right. So third generation cephalosporins, if you remember from ID, that the third generation cephalosporins have good gram-negative coverage. They will cover a little bit of strep. Probably won't cover staph, but do cover that gram-negative E. coli, Klebsiella category of bugs really well. Third generation cephalosporins that we think about, these are IV. And so we have ceftriaxone and cefotaxime. All right, so moving on to esophageal varices. If we are preventing, if we're trying to prevent those esophageal varices from bleeding, what would we recommend? I'm having a really hard time hearing y'all. I'm really sorry about that. Okay. Non-selective beta blockers. So first we have primary prevention. So what is primary prevention?
Never happened.
They haven't had a bleed yet. So we are trying to prevent the first bleed. So for primary prevention, we're going to use non-selective beta blockers. We can use propranolol, nadolol, or carvedilol. What does secondary prevention mean?
It happened, but we don't have it going to happen again.
They've already had a bleed and we don't want it to happen again. And so secondary prevention, we use propranolol and nadolol. What if we were not able to prevent the bleed and the patient comes to the ER and is admitted with a esophageal varice bleed? What do we give them? There's so many in the chats. I love it. All right, so octo something, according to one of the classmates in the chat. Octo something. All right, so octreotide. All right. So octreotide causes splenic vasoconstriction. So splenic is in that abdominal area. And so we want vasoconstriction in that area. We want less blood going to where the varice is bleeding from. So to help stop the bleeding. So the octreotide help the bleeding. Because the patient is bleeding and we already said that they're at increased risk of esophageal varice, SBP, when they have their esophageal varice bleeding, we're going to also give them empiric antibiotic ceftriaxone. And if my husband will let me have another kid, our daughter's name would be octreotide, right? You guys, I'm getting like there's nobody has their cameras on. I can't hear or see anybody. This is
We're here.
all right. So moving on, we're almost done here. Going through the complications of cirrhosis. So the treatment of hepatic encephalopathy. What are we going to use to treat hepatic encephalopathy?
Lactose.
Pharmacologic or non-pharmacologic?
All of the above.
Like a protein like restriction?
Okay.
a diet in non-pharmacologic.
Yeah, thanks, Victoria. So, animal protein restriction, because animal protein leads to the breakdown of nitrogen, which leads to ammonia, which will build up, and the buildup of ammonia is what causes hepatic encephalopathy. All right. So we have a lactulose, which is an osmotic laxative, right? And so that is our first line treatment for hepatic encephalopathy. Adjunct, we can use rifaximin. Remember that rifaximin is adjunct, so it is to be used in conjunction with lactulose when lactulose isn't working enough. Rifaximin is a broad spectrum antibiotic. It's expensive, and again, we should not be using it alone. We should be using it with lactulose. That's what adjunct means, alongside. I'm working alongside the main treatment. How do we know if a patient is getting enough lactulose?
Dr. Hall, I'm sorry, can we go back for a second?
Okay.
When you give the treatment of lactulose, you have to give it with rifaximin.
No, most people start out on lactulose alone, and then if the lactulose isn't working enough, then we add the rifaximin. So if we're not getting enough efficacy, if the patient's mental status isn't clearing up, if they're not feeling better on the lactulose alone, and we've titrated it to the appropriate dose, then we add on rifaximin.
Okay, thank you.
Mm-hmm. So we're going to measure the patient's ammonia, right, to make sure that they're getting better. That's how we know the lactulose is working, right? Is measuring the ammonia levels.
Yes.
Right. Don't walk into that trap on the exam, y'all. So the way we know lactulose is working is that we're targeting to 2 to 3 bowel movements per day. We don't want the patient to have diarrhea, but we want them to have enough bowel movements to be removing that lactulose or removing that ammonia. All right. So even though high ammonia contributes to hepatic encephalopathy and is the cause of that, the levels don't mean anything. So we're not going to measure the levels of ammonia to see if it's working. We're going to look at the bowel movements to make sure that we have enough, and then we're going to look at the patient. Is their mental status improving? Is their fatigue going away? All right. Ammonia levels only help us rule in hepatic encephalopathy when a patient has altered mental status. It does not correlate with how severe their symptoms are, and it does not correlate with how much better they're getting. All right. So the way you know you have enough lactulose is that the patient is having 2 to 3 bowel movements per day. We don't want them having any more than that, because that would be cruel and unusual punishment, right? I mean, it would be cruel and unusual punishment for me. And the risk is that if we go above that 2 to 3 bowel movements per day, we end up giving the patient diarrhea, which can cause a whole host of other problems. All right. So if we are monitoring lactulose, we want 2 to 3 bowel movements per day, and we want their mental status improving. We're not measuring ammonia. All right, so going back, to round out our pharmacokinetics and dynamics in patients with liver failure. If we have reduced hepatic blood flow, how is that going to affect the drugs? So our liver generally helps detoxify, eliminate, metabolize the drug. So if we're having less blood flow into the liver, we're having less drug being run through the liver, we're going to have higher drug bioavailability. Right? We already talked about this, but let's reiterate this. If a patient has low albumin, hypoalbuminemia, so low protein in the blood, what are we going to see happen for drugs? So for drugs that are highly protein bound, they're going to go out of the bloodstream and look for protein. So they're going to have, we're going to have increased drug levels for drugs that are highly protein bound, because there's not enough protein in the blood for them to bind to. So if there's not enough protein in the blood, the levels are going to increase. Right, so ascites, we talked about this already too. So, this is a clue. We've talked about how hypoalbuminemia and how ascites twice today affects drug concentration. So please be mindful of that. So ascites, we have a lot of extra water outside the vasculature. So we're going to see an increased volume of distribution for hydrophilic drugs. For portal gastropathy, we're going to see altered drug absorption. Don't really worry, like there's not a good question I can ask you about that, so don't worry about that one. Because as our liver damage gets worse, we have decreased CYP metabolic activity. What happens? To our drug metabolism and concentrations? So in general, if we have reduced CYP activity, we're going to have reduced metabolism, so then we're going to have increased drug levels in general. Right? If we cannot excrete, if we don't have the biliary excretion, we're going to have increased drug levels. And if we are going into hepatorenal disease, we're going to see reduced renal excretion, which can also increase drug serum levels.
The biliary excretion, is that for lipid soluble drugs?
I'm sorry, is biliary excretion, is that for what?
For lipid soluble drugs?
I am not exactly sure if it affects like a specific lipid soluble versus water soluble. I would think lipid soluble, but we don't need to get down to that detail for this class. All right. So what tool do we use for drug dosing in patients with cirrhosis? Is it the Audit C? Is it the MELD? Is it the Child Turcotte Pugh? All right, so it is the Child Turcotte Pugh. All right, that is all I have. What questions do you have on what we went through related to cirrhosis? I will not be putting a copy of these slides on Canvas because you already have all this information in your lecture slides. Yeah, so the SAG score, SAG score does help us determine if a patient has portal hypertension. So if it's greater than 1.1, it does help us identify that a patient might have portal hypertension. What other questions do you have for me? All right. Well, thank you for playing along. If you're studying and you have any questions over the weekend, I will try to get back to you in a timely fashion. Excuse me. So just reach out via email if you have any questions. All right.
They're thanking you. You just probably can't hear them.
Okay. Yeah, it's really hard.
Thank you.
All righty. Okay. You guys want a break?
Yes.
Yeah, go for it. In Purple Friday fashion. All right. I'm going to hit you with some select alls just to wake you up. Thoughts? What's real confident? What's uncertain?
Real confident. D.
D. D is very confident.
Yes.
Okay,
And
that's good.
C as well.
Yeah.
B. Some confidence with C. Is that what I'm hearing?
See, I would prefer to say both maybe so.
Yeah.
Okay, may instead of can. They're meant to be synonymous here.
Yeah.
Okay, so you guys, I think, got there. Okay. Which A corresponds to Hep B, right? And which can lead to cirrhosis?
Happy.
Only Hep B, right? So only chronic hepatitis will lead to cirrhosis. So an infection that doesn't lead to chronic disease will not lead to cirrhosis. Okay. Bonus points if you can name the player. Thank you. All right. What about comparing between Hep B and C? I told you this is the hardest thing, is just keeping them straight. So we're going to practice. Confident? Any confident answer?
A and B.
Oh, we have A and B confidence. Anything definitely hard no?
C.
C's a hard no. And D is what I've mixed.
But I think C is more likely to be chronic than B.
Okay, good. So there is some differences, but they can. Okay, so I heard everybody felt pretty good about bloodborne pathogens, right? You'll do lots of training on APIs and all this good stuff, right? Both can be acute and chronic. And look, I switched the language myself, may be cleared through natural immunity, with some additional conversation about one being more likely to be cleared through natural immunity, which is hepatitis B, right? Okay. Who we got? Derrick Henry. All right. Okay, good. Hearing good consensus here, right? Fecal oral transmission. Okay. And we got Tyler Linderbaum, our center, helping us here. Hep A vaccines.
C.
Okay, everybody's consensus so far, those that have voted. I'm seeing C. Okay. Good job. Whoop. Sorry, let me go back. To clarify some of the incorrect answers led by Mr. Ronnie Stanley. Twinrix is, do you guys remember what Twinrix is? Twin has both. So it's actually not recommended for post-exposure prophylaxis. None of them are live, okay? D, Habrix and Vacta are interchangeable, okay? And they have the same overlapping indications and everything. So they are both for peds and adults. What is the product that is age specific? That's the only age specific product that we talk, that's not even Hep A, but the one that has the vaccine with the age specific product, if you remember, is the Heplisav B. So for Hep B, there's one that's adult only. Okay. Gamastan. And not that I would use this brand name, but what is Gamastan? It's the immune globulin, right? The first, do you remember the virus? So Hep A. Okay. So if you can think back to the Hep A lecture, there were a couple slides on like what to give when in terms of travel pre or post exposure. And immune globulin was on both of those. So it can be used for both pre and post exposure. As the question stem mentions, remember, immune globulin is passive immunity. It's not as robust and it's only short lasting in comparison to a vaccine related immunity. But the advantage is that it's immediately acting, right, once it's infused. So it's generally given like very soon upcoming trips, right? Or if the patient can't take the vaccine for some reason. So that's like its primary uses. Mandrews, yes.
Is it an infusion or a shot?
It should be an infusion, not like I mean, it probably doesn't take super long to infuse, but I think it's an infusion. Yeah. I think. Now I'm wondering. No, actually, I think it's not an infusion. Now that I'm thinking back to, I think it's just a normal injection. There are all IgG products are all different. Some of them are, and some of them more like I am. Oh, I think I clicked too many times. All right, so serologies, just hepatitis B. Quiet, got quiet. Low confidence levels. Hearing A. Does anybody have any other guesses? And we will walk through it. Okay. So thoughts were acute Hep B infection. So, to me, the first thing I want to ask is kind of are they infected or are they immune? Right. So, the marker that tells me about infection is the surface antigen, right? The marker that tells me about immunity is the surface antibody. So those are always what I look at first, because this doesn't mean anything until I understand the context. So this panel represents infection, okay? They have surface antigen. Antigen is always infection. They haven't developed surface antibody yet. So they have not garnered immunity yet. So when I know they are infected, then the follow-up question you can ask is, when were they infected? Was it more recently or was it longer ago, right? Or more chronic? And we can use the core antibodies to help us to determine that. So in this case, we have positive total core antibody and positive core IgM antibody. So remember that IgM is the type of immune globulin that is formed early on in the immunity process. So the fact that the IgM is still around and circulating suggests that it was a recent or ongoing current infection. So A is the correct answer. Right?
IgM was negative, it would be chronic, right?
If this were a negative instead,
And 6 months.
yes, and you can kind of infer, like it wouldn't be by definition chronic, but it would indicate to you that it was chronic Hep B infection. Yeah, so making this a negative, and that's the only change, the correct answer would be B. And then for C or D to be true, we would need this marker to be positive, right? And then we would deduce from there on. But I think we have another practice for that. Darn it, I'm giving you guys all the answers. Really struggling this week. Okay. Is that as far as I got? Yeah. Well, you guys saw the answer, I think. So which statement is false regarding pegylated interferon? It's not intramuscular. It is a subcutaneous injection. But the true statements are that it can worsen psychiatric or mental health issues, and so you don't want to use it in those patients. It's not for use in decompensated cirrhosis. So that's true. And then because it is not an antiviral, right? It is a stimulator, it is a cytokine or a stimulator or what we call an immune modulator, there's no resistance to be developed to it. We have a patient with chronic Hep B, bipolar disorder, and CKD. Why not, Ernesto?
Plus psychiatric disorders.
Good. So, yep, we just mentioned that on the slide before, right? So we're going to eliminate A because she has an existing psychiatric condition that we do not want to complicate. Anything else you want to eliminate? Because, oh, Jess wants to keep it. Any other thoughts? Anything else you want to, let's get rid of something else because it's not even first line. We didn't even learn about it from me. Yeah, so let's get rid of D because that's second line. And so we're kind of stuck between B and C.
Eliminate B.
Eliminate B because
Can be hard on the kidneys.
good. So the other patient comorbidity of CKD, do you guys remember, is this the OG form of tenofovir or the new improved? It's the older one. So with the older form, one of the main side effects is worsening of renal impairment. Okay, so C is correct. If I would have also, I purposely did not offer tenofovir olefenamide because that would also have been a reasonable choice. But with these 4 choices, entecavir is the preferred agent. All right.
Oh, this is gonna be the reduced antiviral. Doesn't have the acidic environment.
Good, Shawnee. Thanks, A. We got an affirmation there. I only heard a couple, but the 2 that I heard from are indeed correct. So the valpatisvir, ledipasvir and valpatisvir, those are the 2 direct acting antivirals that require an acidic environment for absorption. So patients, they're often contraindicated in patients taking PPIs. And so the risk, not the risk, but because you're not even going to do it, but the reason that you can't give them together is that the PPI will raise the pH of the stomach and hence reduce the absorption of Epclusa or Harvoni, okay? So this is both. So these are two of the combination antivirals that are called pan-genotypic, or meaning they treat all of the genotypes. And I think it helps to think about that, knowing that these were also the two on the simplified algorithm, right? And meaning they work for the largest population of infected individuals. So both of those are good. But it does remind us that genotype 3 tends to be the outlier. So there are medications, there are combinations or single medications that do not treat that. Okay. I'm hearing C for pregnancy test. So what do you remember about ribavirin? Yep. So it does cause a lot of birth defects. So you want lots of, protection, contraceptive measures and testing. What's the other big toxicity? Yeah, to anemia. And when would we typically see the use of this antiviral? Yeah, with complicated, likely previously treated patients. It's not it's an add-on. It's not kind of a standard, first line regimen. All right, one more practice with serologies, looking at them all together. A and C. Good confidence. All right, let's kind of pick this apart a little bit, like you should with any select all. So let's kind of do the easier ones first. All right, so Hep A antibody positive indicates immunity. Hep C antibody negative indicates non-infection, right? So A is true, E is not, okay? Remember, there is one more piece to the Hep C diagnosis, but if it's negative, you're done. You do not further test. So then that leaves us with the middle 4, okay? And this does look different than the prior panel that we looked at. Again, remember, first question I asked myself, are they infected or are they immune? They do not have surface antigen, so they are not infected. They do have surface antibody, so they are immune. And when you answer yes to are they immune, you can then ask, how did they become immune, right? How did they get their immunity? Was it through vaccination or was it through natural immunity? And that's when you can look at the core antibodies to help you with that. this person does not have any core antibodies. So they likely got their immunity through vaccination, right? Because remember, the only antigen in Hep B vaccine is the surface antigen. Okay, so the only way to get exposure to the core antigen is for the virus to be in the body and the body to produce core antibody. So A and C. Okay. Any questions? Good. This one's, the next two go together and they're a little bit tough. I'm hearing A and D. So I'd say the other tricky thing is when the meds are mixed up. Okay, so, and I'm doing this intentionally so we can sort this out. These answers are a mix of Hep B antivirals and Hep C antivirals, if that helps. One rule of thumb is the brand name. We're going to use the brand names for Hep C because they represent combination antivirals. So A and D are Hep C combos. What are our Hep B treatments? Path and entecavir. And we already talked about ribavirin, which is an add-on Hep C, but and other things. If that helps a little bit. So who is at risk for Hep B reactivation? That involves a black box warning.
Hep B and Hep C and start Hep C medication.
Perfect. Yes. So exactly. If you have Hep B and C co-infection, we know that starting Hep C therapy can pose a risk for Hep B reactivation. Okay, so those are our key Hep B direct acting antivirals. And then similar question, but now related to abrupt stopping of the medication. How does that change? So they're also at risk for reactivation when you abruptly stop the Hep B therapy. So those are our two Hep B antivirals. Okay. So these are tough, but I'm trying to put questions together that make you really know more than just, know more than just one fact. Now you're kind of putting multiple facts together. Okay. Last one, I think. I'm gonna vote for C. Okay, have a few seconds and thirds for C. Okay. Um, so, Hep C is primarily transmitted bloodborne, right? Right. Hep B is one that has a primary transmission of mother to baby, as well as bloodborne. B, do all patients, so obviously no, because this is not true. If you remember the Hep B algorithms, remember the purples and the blues? So, yeah. Exactly. So you use the patient's ALT levels and the viral load or RNA levels to plug into the algorithms to determine whether or not they need treatment at the moment. And then you continue to monitor them, and that kind of changes over time. So not everybody is uniformly treated with the diagnosis of hepatitis B. Hepatitis C, everybody is recommended unless they're not going to survive treatment. All patients with chronic Hep C are recommended for treatment. Hep C indefinite antiviral. Nope. Do you remember the two general timeframes? 8 or 12 weeks, depending on the treatment strategy. And then they can be cured, right? And then most adults are just recommended for screening once a lifetime, okay, not every year. The only patients that get screened every year are those at very high risk, such as injection drug users. So B is true. Remember, most patients, adults, will naturally clear as the ages go down. Pediatrics and neonates have a lesser likelihood of natural clearance. See you Sunday at 6:30. I'll be warm in my house. The Ravens will be freezing in Buffalo.
You beat the bill, so we got a bonus on the test.
I'll think about it.